Welcome back, class. Now we're going to get a little more into I guess, into the weeds of healthcare when we're talking about does it match up with um, the rationale of real world, maybe the real world version of a competitive market. And Dewar takes maybe a little different approach to this than I might take, but I think her rationale, the way she structured this chapter of her text um, is not too bad. I think she's hitting all the salient points. One thing that she does, she phrases things a little differently than I do. But what we want to do is just to go through and think about again, think about both sides of that financial coin as we go through this. We've touched on some of it in the first segment, more of an overview of the competitive market and at least how economists view competitive markets in general. And we did touch on some of it with how the healthcare marketplace matches up with that. But what we're going to maybe get a little more in the weeds on this one, and I'm going through the set of notes that you have out loaded out on the internet. So grab those notes if you want to follow along. But as I start working down through the notes, it's talking about sellers possessing tiny market shares, selling a homogeneous product, no barriers to entry, perfect consumer information, actual competition because substitute firms offering identical products. Nothing prevents new firms from entering the market, and no single firm has market power. And for the most part, a lot of that does apply to healthcare. I worked for several years in, at least in the California market, but I worked for several years for Health Net, and it was more of a West Coast commercial plan. And so we, not only West Coast commercial, but had a government specialty. They did Medicare Advantage, did Medicaid, had some VA business, did a lot of TRICARE business. So when you're looking at the commercial plan, they provided what I'm going to call a full suite of goods and services. They provided commercial insurance, they had Medicare Advantage, they had Medicaid, they had TRICARE, they had VA. And so what they were faced with in especially in Southern California, and if you think if you're not familiar with Southern California, the way it's laid out, but if you go out east and north of LA, you get into what they call the high desert. You may have heard of Barstow, California, but that's kind of, Barstow, Hemet. They're located in that high desert, and there's some military bases there. You've got 29 Palms. It's a huge Marine base. You've got Edwards Air Force Base. You've got the Army base there just outside of Barstow. And so a lot of healthcare goods and services, and unfortunately, not a great supply of healthcare providers, because healthcare providers had rather live in San Diego. They'd rather live in San Diego, at least at that time, San Diego, San Francisco, LA. Maybe in the environment that we have now, maybe they might change their mind and decide to live in the high desert. But there were providers there that it was almost a monopolistic situation, because there was not a supply, and if health plans wanted to play and provide services in those market areas, they had to pay a premium for those healthcare goods and services. Same thing with the Monterey Peninsula. And there were some hospital systems in Northern California that, they and it wasn't just Health Net, it was a lot of health plans had a difficult time negotiating with a lot of the hospital systems in California. Same thing in the Buffalo market, and I'm sure the same thing exists in that Nashville market. There are some providers And when I call providers on the when you're looking at that financial coin, they fall as a provider, they fall into the seller of healthcare goods and services to health plans. Health plans turn around and bundle those services in the form of networks and benefit plans, and they become sellers to employer groups. And it's the employer groups that are consuming those goods and services. So you can kind of look at it as it's really the two factors in the market are the provider groups that are actually generating or producing the goods and services. And over here on the employer groups, you've got the consumers of those healthcare goods and services, and you've got the health plan in the middle. And the health plan, it kind of serves as a clearinghouse. That the health plan's a clearinghouse. They bring buyers and sellers together and ensure that both sides are functioning according to the contracts that they have signed or agreed to. Providers have agreed to a price. Employer groups have agreed to a benefit plan for their members, and health plans bring everybody together, and it helps make the markets efficient. And as Adam Smith would tell us, that invisible hand in the market is driving the prices and quantities to equilibrium in that market. Now, perfect competition also hits on one of the three pillars of, again, economic thought: opportunity cost, self-interest, making decisions at the margin. And especially, it's the self-interest that kind of focuses on perfect competition, because perfect competition also entails utility and profit maximization. Consumers, I'm a consumer, you're a consumer of healthcare goods and services. Consumers are maximizing utility. Their self-interest is maximizing utility. Health plans, provider groups, doesn't matter whether you're on the provider side or the payer side there, they are interested in maximizing profit. So within the healthcare environment, you have a lot of self-interest that is driving the decisions made in that healthcare market. And the third bullet that's on that slide that I took from Dewara's text, she talks about nonprofit status implies that medical firms don't strive for profit maximization. Licensure drives barriers to entry. Consumers and clinicians typically lack perfect information regarding prices and technical aspects. And at that point, physicians can become opportunists. So that's a lot to roll into one bullet, but if I tear it down, to me, nonprofit is just a tax designation. Nonprofit, and it doesn't matter whether it's a health plan or a provider, nonprofits are there to make money. Profits are, providers are there to maximize revenues. Health plans and a nonprofit is there. They have to make profits too, because they have to ensure that they have enough money to continue providing healthcare goods and services through benefit plans to employer groups. So all of these nonprofits are in the business to make money. You can either be for-profit from a tax perspective, or you can be not-for-profit from a tax perspective. There are licensures that drive barriers to entry. And more importantly to me, and that bullet it talks about the imperfect asymmetric information that exists, and we've talked about this before, that exists between consumers and clinicians. Consumers are maybe not the most forthcoming when they go to the doctor's office, especially when they ask you the questions about, do you smoke? Do you consume alcohol? Do you consume drugs? May not be the most forthcoming. On the flip side of that, you've got the providers that they know what they're going to receive for providing those healthcare goods and services. They know how to maximize profits, and they may become opportunists because they may have a buddy down the street that provides radiology services. They have some kind of an agreement worked out with him that they will send patients his way, or maybe a specialist somewhere along the way that they have an agreement worked out with. So you just don't know what the financial drivers are when you go into your physician's office, because again, it's asymmetric information. And then the fourth bullet on there, they talk about supply and demand, impact of market changes on prices and output. And that's what drives the market, supply and demand. Healthcare markets are reasonably competitive and they're comparative market models. And if I think about when you go back to the two things that a profit maximizing firm or entity, two decisions they have to make is how much do I produce and how do I price it? If I think about healthcare, and we'll just take Medicare or Medicaid as an example. CMS sets the fee schedules. There's no negotiation with providers when if they accept traditional Medicare, if they accept Medicaid from a government agency, those prices are set with the fee schedule. Managed care organizations negotiate, and when those negotiated rates are set in stone, if it's a 1-year contract, a 3-year, a 5-year contract with some kind of price escalators on an annual basis, those rates are set in stone. So, and everything there is based on supply and demand. CMS is setting fee schedules based on historical pricing information and cost information they get from providers. But again, not a lot of negotiation, not a lot of wiggle room. And once that price is set, it's pretty much set in place for an annual basis. Health plans are notorious for negotiating their rates based on what they term network adequacy. Could be a federal mandate, a state mandate, maybe just an internal mandate that the health plan has that they have to have X number of providers for every 1,000 members, and they have to have a distribution of specialists. And if it's in an area where they are, afraid they're going to have network adequacy issues with orthopods, cardiologists, neurologists, anesthesiologists, they may be willing to pay a premium, because if network adequacy parameters and metrics aren't met, they can't sell those benefit plans to employer groups. And health plans are not only, they're going to base a lot of their rates and their negotiation strategies on market rates that they already have with other provider groups or other hospitals. They're going to base their negotiation strategy based on numbers that their actuaries give them, or numbers that their healthcare analysts have generated based on historical claims information. Here's what it was last year. Here's what we think it's going to be this year. And here's the rate that you can negotiate for this bundle of services in order for the health plan to make money. Also, that when health plans are negotiating with employer or with medical groups or hospitals, they are getting pushback from employer groups. Employer groups have a preconceived notion about quality that Hospital ABC provides. They have a preconceived notion about quality that a specific medical group provides. Maybe it's a group that their employees want. So there's all of this. There's also some pushback from employer groups with respect to how a managed care organization negotiates their rates. And then we jump to the next page, and it talks about perfect competition implies that consumers and producers maximize personal utilities and profits. That's just basic tenets of economic thought. Massive number of market participants indicates that everyone is a price taker, but because no individual can influence a market. And that's true. If, I don't know that, that at least as an early adult, let's say, when I was an undergraduate in Kentucky, Nashville, if you wanted medical services in Nashville, you went to Vanderbilt. That was the, bright and shining star of the hospital system in Nashville. I'm sure now that there are a lot of good hospitals in Nashville. So that I'm not sure that Vanderbilt might not have that market power that they might have had at one time. and that's what the competitive market in healthcare, that's what drives that competitive aspect of the market in healthcare is no one individual. They talk about individuals, or Dewar talks about individuals, but in essence says no one firm has the market power to drive prices and quantities. It's not a monopolistic market. It is a competitive market to a certain degree, and price competition factors or forces of supply and demand are driving those rates and driving those quantities in any individual market, whether it's Nashville, whether it's Atlanta, whether it's any market in the United States. Consumers maximize utilities via consumption until marginal private benefit equals price. And to me, just talking about marginal benefit equals the price. You've got a certain level of marginal benefit. My price, again, for or my marginal cost, it's not just my copay that I pay. It's, again, and I've talked about it before. It's it's the amount of time I spend going to the doctor. It's wear and tear on the car. It's parking when I get there. It's there's just a lot of things bundled into that $10 copay I have to give my primary care doc when I go there. Profit maximizing firms will produce goods and services until marginal private cost equals price. And again, at the end of the day, the formula that clears the market is marginal private benefit equals price equals marginal private cost. And again, marginal return equals marginal cost. At that point, firms are maximizing, and that's those types of decisions at the margin are going to help clear the market. Market demand curve is downward sloping, reflecting substitution income effects of lower price and diminishing returns to marginal private benefit. If you think back to your micro classes, to your microeconomic classes, what are the three things that drive the slope of that consumer's demand curve? Substitution effect, or prices of comparable goods. Income effect, as prices go down, right? Prices drop, and from a consumer's perspective, if prices drop, more quantity is demanded. That gives you that slope. And on the income effect, as prices drop for healthcare, and it takes less of your budget for healthcare, there's a boost in income because at least in real income, there's a boost, so you can take part of your budget constraint and spend it on going to the movie, going out to dinner, buying a new car. And that's where you're talking about the income effect. And then the third thing is that, diminishing marginal returns. So at the end of the day, that demand curve for healthcare goods and services is going to be downward sloping. Market supply curve is upward sloping, reflecting the increasing marginal private cost, variable cost of labor and materials of production. Remember, producers produce if they are going to make a profit, and at a higher price, they feel like they're going to make a profit. So that supply curve is upward sloping. It's the law of supply, law of demand. Price decreases, more quantity demanded is going to be sought by the consumer. So it's downward sloping. And at that intersection of supply and demand is going to be the equilibrium price and quantity in any market, healthcare included. And top of the bullet, the top of the next page, market equilibrium, utility maximizing. That's me. I'm a consumer. I'm maximizing utility equals profit maximizing. Provider that I'm going to see is in business. They're providing. They get up, take a shower, get dressed, come into the office every day and provide office visits to not only myself, but a lot of consumers in the Atlanta market. And they do it for one reason, because they want to make a profit. Is reached when price and quantity delivers MPB equals MPC, and that's what's going to clear the market. Consumer surplus versus provider surplus. The sum equals to total net gains from trade, and inefficient allocation of resources can result in market participants focus too much on MPB equals MPC and not the full social impacts. And now we're talking about the impact on society. We're talking about the impact on that part of society that may not have the financial opportunity to seek healthcare goods and services. And that's where DeWara is talking about the inefficient allocation of resources. And it doesn't matter whether you're on the provider side or you're on the health plan side. So it doesn't matter whether you're a provider or a payer. If you look at that third bullet, it says comparative statistic analysis evaluates how changes in market conditions shift the supply and demand curves and the resulting shifts in equilibrium prices and output. So if I go back to my most recent health plan experience, so we're talking about the Buffalo market. I had some healthcare analysts working for me. The chief actuary had a group of actuaries working for them. Strategic planning had some analytical dudes in there working on what they call competitive and comparative comparative advantage reports. And from a health plan's perspective, that was viewed as like really secret squirrel stuff, because when it was presented, especially at the senior management level, the copies were given out and they weren't allowed to leave the room. I mean, it was almost we didn't lock it away, but it was not for sharing with just anybody, because it was sensitive information that the health plan had generated based on where they thought the comparative advantage was with all of the other health plans in the market, where the comparative advantage was in being able to develop a benefit plan that they could sell to employer groups, and a negotiation strategy, not only on the sales side where they were selling to employer groups based on premium, but also on the network management side where they were trying to negotiate rates with the provider groups in the area to build these price competitive networks. So, from a health plan's perspective, in a given geographical area, or let's call it a regional market, they are trying to develop price competitive benefit plans that they can sell to employer groups. So that's the revenue piece of it for the health plan's perspective. The cost piece of it is how well network management could negotiate prices with providers on the other side of the financial coin and manage the healthcare cost of goods and services. So at the end of the day, remember, profit is revenue minus cost. And so the health plan wanted to increase revenue through sales as much as possible, but drive the cost down through negotiating strategies with the providers groups as low as possible. And to some extent, it's the same thing on the provider side. They're wanting to drive revenues through negotiating the best price possible with the payer side of that financial coin, but they're also trying to drive their costs down through minimizing their labor costs, minimizing the cost of their capital stock, minimizing the cost in the lease on the building. So everybody, doesn't matter which side of that financial coin that you fall under or fall on, everybody's trying to maximize revenues and trying to minimize costs, because at the end of the day, everybody's trying to drive profits. And when you talk about that last bullet, the number of buyers, individual preferences, disposable income, prices of substitutes, and complements shift the demand curve. Again, I think we've talked about it in the past when you talk about these are what economists refer to as demand shifters. If you look at the downward sloping demand curve for healthcare goods and services, pricing is going to, at multiple prices without that demand curve shifting, each price is associated with a quantity demanded. Where it gets interesting is if that demand curve starts to shift out and through expansion, through consumers demanding more healthcare goods and services, which is going to impact the cost on the health plan side, or does it start to contract? And is the health plan doing something to help ration those goods and services so that the demand of the healthcare goods and services contracts? Consumers aren't consuming as many goods and services, and at the end of the day, it helps to control the health plan's, cost of doing business. So that's where you're looking at demand shifters, and it'd be the same thing on the provider side. Provider side is looking at simpler, they're looking at how the demand is going to shift in the market, but on the provider side, they are starting to look at more the supply shifters. So on the provider side, you're talking about the number of providers in a given area. You're talking about input prices, the factors of production. You're talking about technology impact, production cost. How does that shift that supply curve? Does it shift it? Does the supply curve contract? Does the supply curve expand? So you've got on the provider side of that financial coin, they're concerned about these supply shifters that are going to determine how they provide those healthcare goods and services, how many they bring to the market at a given price. But they've also kind of in their peripheral vision, they are looking at what is the health plan doing? What is the health plan doing? Is it through medical management? Is it through contract negotiation? Is there through their preventive health care programs? What is the health plan doing to try to contract the demand side of that? So depending on the way the health plan manages the demand side and the cost of producing those goods and services are going to directly impact the decision of any provider as they go, not only in the short run. In the short run, they can determine that they can lay off individuals or constrict their labor force, or are they going to expand production in the short run by hiring more people to generate these goods and services? Second bullet on that page, it says, in a competitive market, prices and quantities shift to mitigate shortages and surpluses. And that's exactly what happens. If you've got a surplus of providers, health plans aren't, compelled to negotiate rates any higher. They're going to try to negotiate, lower rates if you've got a surplus of providers. If you've got a shortage of providers, health plans are forced to, in some instances, to negotiate higher rates. Again, Adam Smith's invisible hand. Market forces are driving through supply and demand model. They're driving the market to equilibrium prices and quantities. And depending on whether we've got a surplus or a shortage, it's driving that supply and demand in different directions to eventually end up with a market equilibrium that's going to drive that price and that quantity in equilibrium. Prices actually, if you're an astute individual at a health plan, or you're an astute individual at a provider group, or even to some extent, if you're in the consumer population and paying attention to what's going on, prices generate information to consumers and producers to indicate relative availability and value of the good or service. It creates market clearing conditions. It rations and distributes services among consumers who value them the most. It's an incentive mechanism. More or fewer resources during shortages or surpluses. So if everybody's paying attention to prices, it just expands the depth or the breadth of the information that you have on the provider side. It expands the breadth of information that you have on the payer side, and it can also expand the breadth on the depth of the information on the consumer side. So, and one way it does that is each time you let me think for a few minutes. Okay, so typically, if you're working for an employer that provides you with a benefit package for your medical care, usually it's October, November, it's called open enrollment, and everybody goes out and they decide, what benefits they want and, how much they're willing to pay, and the employer group, based on what they're going to have to pay on a premium basis, they are going to say, if you're an individual, you're going to pay this much. If you're an individual plus a partner, you're going to pay this much. If you're an individual and a family, you're going to pay this much. And based on how much they are charging you as an employee to come out of your paycheck, it's going to give you an idea of kind of what the healthcare market structure is for that particular market. So, and typically employer groups, based on what they're going to have to pay as far as increases in premium, they're going to pass on a certain percent of that to their employees. And if their employees are paying attention, they're going to have they can determine some level of information regarding shortages and surpluses of providers in the market. Same thing with providers or payers as they go into the negotiation process, and typically November, December of every year, trying to get those rates solidified for January the 1st. If it's like an annual negotiation, they're going to have a pretty good idea based on the negotiation positions what the surplus and shortages are in the market. In a competitive market, firms enter and leave the market with no barriers or entry as profits change. Profits drive expected rates of return, which is exactly the case. And what typically happens in a competitive market is competition drives what they call normal profits, occur when revenues adequately cover the opportunity cost of all inputs. Excess profit shifts the supply curve to the right. So more profits going to shift that supply curve to the right, because you're going to have more people want to come into the market to provide those healthcare goods and services because they see more profit potential in that market. And below normal profits shifts the supply curve back to the left. They're going to get out of the market if at all possible, if they can't determine they can make a profit. And it doesn't matter whether it's on the provider side or the payer side. Purveyor side, if a health plan can't make a profit in a particular regional market, they're going to leave the market. If providers can't make a profit in a particular regional market, they're going to leave the market. It's profit. It's the price and the profit that is driving the entry and exit. And again, depending on the contracts that you have with suppliers, whether you're a payer or whether you're a provider, is going to determine how easy or difficult it is to exit that market. And lastly, profits serve as an incentive mechanism to allocate resources and determine efficiencies in the market. Again, profits driven by price are going to determine the supply and demand in that given market. And again, that invisible hand, those market forces are going to drive that market using the supply and demand model to equilibrium. And that's going to wind it up for us on the competitive market. Hope you've enjoyed it. I can't remember what the next chapter is about, but the next time you see me, we will start into a new chapter. Talk to everybody soon. Thanks.